I'd like to thank the conference organizers for asking me to be here with you. And I think these breakout sessions are meant to be a little bit more workshop-y. And so I'm going to try not to take the whole hour to talk to you and leave lots of time for us to discuss things. Oh, I was told that this clicker works. I have the first clicker that works today. So as was mentioned, I do clinical trials, which by necessity are funded by industry. So I have a number of disclosures here. None are really going to be pertinent to what I'm discussing today. What I will be discussing today is I'll be reviewing opportunities for improvement in outpatient care of persons living with dementia provided by just the memory clinic model in general. And I think this will actually segue nicely from some of the things that Dr. Gauthier was talking about this morning. I'll explain the concept of a learning health system model, and then I'll describe how we are attempting, I don't think we've arrived there yet, but how we're attempting to use that learning health system model and incorporate that into the model of care that we're using in our memory clinic in Victoria. And I will try to be very clear about when I'm giving you data and when I'm giving you opinion. And if any of the opinion part is something you disagree with or something you would like to add to, then I look forward to a good discussion. So I'll just review the concept of memory clinic in general. This is always such a nice conference because there's such a broad cross-section of people here. And I think some of the attendees do work in a memory clinic. These are specialty clinics that were established by and large in the 1980s across the developing countries. When people a decade into the development of memory clinics took pause to kind of think, well, what's the purpose of a memory clinic? These goals were identified, at least in one paper, as the goals of a memory clinic. So these are outpatient clinics where people go with the goal of to forestall deterioration in dementia through early diagnosis and treatment, to identify and treat disorders other than dementia that may be contributing to a patient's problem, to evaluate new therapeutics, to reassure people who are worried when no morbid deficits are found. And I think if we look at the goal of memory clinics that exist today, 40 years later, they still fit into these goals quite a bit. And memory clinics, since their inception, have proliferated very widely, especially in developed countries. So in the Netherlands, for example, in 1986, there were only 2 memory clinics, and in 2016, there are more than 100, for example. But there are important regional, national, local contexts about how memory clinics are organized. So again, from that paper looking at the development of memory clinics in the Netherlands, we see that in the Netherlands, they are frequently staffed with specialist physicians, neurologists, clinical geriatricians. Over time, family physicians with added competency in elderly care have increased their presence in memory clinics, and I think we're finding that in Canada as well. Interestingly, over time, psychiatrists have decreased their presence, and that may be in part due to stretched resources. I'm not quite sure. What's really interesting in the Netherlands compared to Canada is the presence of psychologists in almost 100% of their clinics. And unfortunately in Canada, and especially in BC at least, psychologists aren't covered in the publicly funded healthcare system. And so we have very difficult access to neuropsychologists in our memory clinics, whereas there's almost universal access in the Netherlands, even outside of those clinics located in academic centers. What's a little bit different, again, from the Netherlands compared to Canada is I think many of our memory clinics are more well equipped with other disciplines, such as social work, occupational therapy, for example. And you can see that the proportion in Holland is less. So there's certainly variability in how these clinics are set up. And even within a province, there's going to be quite a lot of variability. If you look at the clinic at UBC, for example, compared to the clinic at St. Paul's and compared to our clinic in Victoria, there's quite a lot of difference in how they're organized. And a kind of a Canadian innovation as well has been the development of primary care-led memory clinics. This has been the work of Linda Lee, who's presented at this conference before, who came up quite rightly with the idea that we're not going to train enough specialists to take care of everyone with dementia. And so if we put the activities of a memory clinic in the context where we can put primary care physicians who take on the responsibility and the expertise to do a good job with this, that can probably take care of 80% of the patients who need taken care of. And from her initial clinic more than a decade ago, there are now 119 clinics that have followed her model, including a couple with us that I'll talk about a little bit later. So this is opinion. What are the characteristics of an ideal memory clinic? And I would argue that I don't think that we are there for most of us, but this is what we should aspire to. Well, and like any specialty care, they should be easy to access, right? So patients want care near where they live. And so geography is an issue, but even beyond geography, the referral process, how convoluted is it for me to get seen? Does my primary care practitioner know how to send me to this clinic, for example? And once I'm sent, what's the wait list like? Is there some management system in place for the wait list to ensure that everybody gets seen in a timely manner, or at least an equitable manner? And once you're there, the characteristics of an ideal clinic in my mind would be that they provide comprehensive and timely diagnosis using up-to-date diagnostic methods. And we just heard a great talk on some of those up-to-date diagnostic methods, for example. But beyond technology, that also includes interdisciplinary assessment, so access to various disciplines that will have a positive impact on the diagnosis and treatment of the patient with dementia, and then also access to the up-to-date technology. We hope that a memory clinic can have programs that allow for referral and therapy across the spectrum of cognitive decline. I remember one day working where I had 3 referrals that were very brief. Please see this patient with memory issues, and that was it. And one of the patient ended up having subjective cognitive decline at worst, very, very mild problems. One of the patients had mild cognitive impairment, and the other patient clearly already had established moderate dementia. And so I think we see patients across the spectrum of cognitive deterioration, and it's important to remember that we want to be able to help patients across that spectrum. And so that involves, where they are available, providing access to cost-effective pharmacological therapies, but also providing access to non-pharmacological treatments. We hear it over and over again that care partners and family members are an integral part of the patients presenting to memory clinics. And so providing care for care partners and family supports is really an important characteristic. And in an ideal world, seamless integration with community resources. So we can't do it all. There are organizations in the community. Sometimes those are within the publicly funded healthcare system, and sometimes that refers to local organizations, such as community recreation centers, for example. Sometimes it involves links to innovative programs. So in Victoria, we're very lucky to have Professor Deborah Sheets at the University of Victoria, who started an intergenerational choir for persons with dementia, the Voices in Motion choir. She's also started a memory cafe. Being able to link our patients directly with those kinds of opportunities is really important. And there's some posters, some interesting posters here on social prescribing, which is really one effective tool for doing that. And also integration with larger organizations such as the Alzheimer's Society, for example. And there are arguments that sometimes bringing those organizations into the clinic can provide some of that seamless integration as well. And the characteristics of an ideal memory clinic would provide follow-up as appropriate, although I don't know if anyone's defined appropriate follow-up at this point. And it's a moving target. Unfortunately, our reality is that a good proportion of our patients now don't have a regular primary care practitioner that they can go to. They're stuck going to walk-in clinics. And so those patients probably have very different follow-up needs than the person who has a longitudinally established relationship with a nurse practitioner or family doctor that they've been seeing for a number of years. And also providing access to research opportunities for patients. And my strong bias is that in areas of medicine where therapeutics are limited across the spectrum, often the impetus to be able to provide research opportunities for patients is greater because they have fewer run-of-the-mill opportunities available. And patients come in and they say, well, okay, I've got this diagnosis of Alzheimer's now. I guess I better go off to the Mayo Clinic to find out if there's some research trial I can participate in. And ideally, we wouldn't have to have that kind of a scenario where we say, well, no, there are some research opportunities you can participate in right at home. So these are what I think any memory clinic wants to aspire to, and perhaps none quite get there perfectly. But if you keep this list in mind when you're designing your systems, that might allow you to get there. Now, challenges to the memory clinic model in general is that there may be a lack of evidence that they actually work, or there's mixed evidence. Now, it depends on how you obtain that evidence, but there was a study that was quite highly publicized, again, in the Netherlands about 10 years ago, I think it was, where there was a randomized trial where they took 197 family practices that were linked to 6 different memory clinics. And they took patients presenting with memory complaints and randomized them to either be treated by their family practice or to be sent to a memory clinic. And they didn't see a major difference in outcomes in terms of patient satisfaction or other measures that they used in that study. On the other hand, Dr. Lee, who is spearheading the MINT Memory Clinic network that I spoke about earlier, is going to publish shortly an economic analysis that's been done in Ontario showing that the presence of MINT clinics has saved approximately $51,000 in healthcare costs per patient going through the clinic. So I think the evidence really depends on how you're looking at the evidence. But another real challenge of the memory clinic model, especially in Canada, is that they remain concentrated in academic centers. Although, again, there are innovations happening. There are certainly clinics that are being developed outside of academic centers, and there are clinics that are developing models to reach outside. The pandemic really sped that up, but even before the pandemic, there was the model of Dr. Drew Kirk in Saskatchewan, who's been pioneering a rural and remote memory clinic for many years now. They tend to be specialist-led, and again, we're at the forefront in Canada of providing generalist-led memory clinics, but there still are specialist-led, and that creates a problem. It creates a bottleneck because there's a lack of trained personnel across all disciplines. So not just geriatricians and neurologists and geriatric psychiatrists, but there's a lack of occupational therapists with particular training in dementia assessment, and social workers, and even nurses. So that's a challenge for sure. And to me, the biggest challenge is a lack of centralized coordinated care model across a jurisdiction. And I was really happy to hear Dr. Gauthier talk about cancer care as a model, because that's really what I have in my mind. In British Columbia, if you have cancer, there is a public health services health authority of BC that runs BC Cancer. And the concept behind that is that if you are in Atlin, BC, or if you're in downtown Vancouver, you get access to a certain standard of care for your cancer. We don't have that for dementia. It's very ad hoc. And so if you live in a rural community, you may have no access to a memory clinic type setting, or you may have indirect access because somebody knows how to refer you and you need to drive 8 hours south to go see someone. And so, and even within the different clinics, these clinics are all built from the ground up. So we don't have kind of standard protocols or standard patient pathways that we follow. And that's something that's lacking, I think. That leads to variability in the type of care that's provided across clinics. And the mission of the clinic may depend upon the initial funders. So clinics that were started more with a mandate for accumulating patients for research may have more of a research focus versus clinics that maybe started more with a philanthropic donation, for example, may have other focuses to them. So our memory clinics in Victoria are a relatively new phenomenon, and I'll talk about how they came about. We have a specialist clinic based out of the Royal Jubilee Hospital that's embedded within our seniors outpatient clinic. And so I work there along with colleagues in geriatric medicine, geriatric psychiatry, and a nurse practitioner. We have a nursing unit administrator, an OT, an RN, a social worker, and through the seniors outpatient clinic, we have rapid access to physiotherapy, nurse continence advisor, and pharmacist. So we're really quite blessed with the complement. Of course, we never have enough people to deal with all the patients, but I think that's across healthcare. It's not a surprise. And then we have had 2 primary care memory clinics based on the MINT model, one in Victoria and one in Nanaimo, that are also staffed by GPs who have done extra training to familiarize themselves with dementia assessments, and a complement of allied health as well, and access to specialists. And we're working on tightening up the relationship between the specialists and the primary care clinics so that we can give them help when they really need them with their most complicated patients. So an example is the physician in the primary care memory clinic is probably not the one who's going to be doing a lumbar puncture for CSF, as you've just heard, but they may have enough expertise to say, I think this is a patient who needs it. Can we talk to you really quickly to help us access that, for example? So as I mentioned, our clinics kind of came not because the health authority decided that they wanted to invest and create the memory clinics, but really because we had a donor-initiated collaboration. So we had the Manning family donate some money with a fairly vague but important goal, which was we want to improve access to diagnosis and diagnostic and treatment options on Vancouver Island. That was their stated goal. And so clearly some of that funding needed to be used for research, but in order for research to be successful, we needed a place where patients were actually seen in some sort of coordinated manner. And I think that kind of lit a fire under our health authority just to say that, yeah, this is something we should be investing in. And I'm actually, quite happy that they did invest during all the distraction of a pandemic and the distraction of the million other things that happened in a health authority and helped us to get our clinics going. It's always slower than you expect it to be. There's always more speed bumps than you expect it to be, but we have gotten somewhere. But I don't think it would have started without the philanthropic impetus here. But the advantage of being sort of late to the game and having a relatively recently designed clinical system is that we can be a little bit intentional about how we want to design the clinic. And this is where the question of designing the clinic as a learning health system was brought in. So I'm going to shift gears and talk a little bit about a learning health system and give you an example of how we're trying to incorporate that model into our clinic. So this is a fairly wordy definition here, a system in which science, informatics, incentives, and culture are aligned. You can read the rest. What it basically refers to is a shift from the traditional linear model of how knowledge is incorporated into healthcare. So usually we have the ivory tower academics who are busy squirreling away and generating research papers. Those research papers are read and digested by educators of all sorts, and healthcare professionals are trained according to the latest standards and the latest knowledge. Those healthcare professionals then go out into the world and develop programs of care, and then there's the one-on-one interaction that happens between a healthcare professional and the patient, and it's a very linear type model, and there's insights lost at each of those steps. And the idea of a learning healthcare system is to wrap that around. And so it's to say that you use the data that you're generating during healthcare encounters to feed into the ivory tower and to provide evidence and to shift practice right away. And you have this continuous cycle here. So one of the health policy researchers who's done a lot of publishing on the learning health system is Charles Friedman. And this is his model here, where he has kind of three pillars or three areas where the atomic cycle of the learning health system occur. So one is just at the point of care of practice, where at a basis you have to be capturing what you're doing in practice as data. And that can then go to generate knowledge. And so you have teams that can help you assemble the data, analyze the data, incorporate external evidence into that data, interpret the results, and then design new interventions for your clinical scenario. And in the course of that, there's a formation of a learning community that helps to continue to drive this. Okay. Mianyar and colleagues have looked at this in the Canadian context. These are researchers out of a Health Policy Institute in Quebec, and have said that, in order to have this atomic cycle of the learning health system, you have to make sure that this is recognized at different levels. So it has to be at the micro level in terms of the healthcare setting where you're trying to implement this learning health system, but it also needs to be supported at the meso level. So for example, the hospital or the health authority, and at larger scales such as regional and national scales. And on top of that, the pillars upon which that system is based have to be aligned in terms of social, scientific, technology, policy, legal, and ethical. And so it's only once you have that underlying buy-in at different levels that you can really create a system like this. And then the outcomes that you measure to judge the success of your system can be things like patient experience, they can be provider experience, they can be economic considerations, or they can be health of the population. And how you weigh those different outcomes obviously determines on the value that you assign to them. And what's important is that you're really creating a common infrastructure that can support multiple cycles of this that may be occurring at different speeds. And I'm going to give some actually very low tech examples of this that sort of show how we're trying to shift the culture within our memory clinic to really adapt it as a learning health system. I'd have to say that where learning health systems have had the most success from my understanding is in acute care. And there are really good examples, for example, in critical care units. And that's because a critical care unit, for example, is already a really data-rich environment. You know, you have all sorts of numbers about length of stay and numbers of people who get pneumonia and numbers of antibiotics prescribed and which antibiotics are prescribed. And that data is already is captured for you. And so if you have a problem, for example, like your local critical care unit has a 15% higher rate of pneumonia than your neighboring hospital, you can quickly dig into that data and try to understand, and you say, oh, well, it's because our antibiotic prescription patterns are different. You can put into place a new protocol for the treatment of pneumonia in your ICU, and within a couple of months you have that cycle completing itself. Problems that are in which the data is inherently more messy and in which the solutions are inherently more complex, those cycles are going to be much longer to do. But if you have an infrastructure in place where people have the time and the space to think about this, you can have cycles going on at different speeds. And I think there's an advantage of a learning health system approach. And I really think our healthcare system in general needs to move towards this because it leads to directly improved experiences for patients. It promotes evidence, research, and innovation to inform practice and decision-making. It's not just, well, this is what we've always done, and that's what we're going to keep doing for the next 20 years. Increases workforce satisfaction, improves system value, and can reduce practice variations. So I'll give you a concrete example. Again, one that's kind of not so high tech to show that you can tackle this in a real way. So just to go back to some definitions, we've talked about this already today, but mild cognitive impairment or mild neurocognitive disorder defines the syndrome where patients are presenting with objectively validated subjective concerns that don't impair their day-to-day function, unlike dementia, where day-to-day function is impaired. And we can have large talks on how you determine whether someone has impaired function or not. But the importance of mild cognitive impairment, on top of the fact that patients are coming and saying we need help with this, is the fact that it may be a prodromal state of dementia. But often, as you heard from Dr. Gothi this morning, patients have retained insight and they're actively seeking help when they have mild cognitive impairment, which may be different than some patients who have more advanced dementia, for example. And prior to our memory clinic and prior to the learning health system, there was a locally developed psychoeducational course that had been developed for patients with mild cognitive impairment that needed some updating. The difficulty, of course, is we had no outcome data for this course. So a therapist in the clinic at one point had developed a course that seemed to be working and then kind of died off as people got busy. And so the thought was, well, we should start this course again. And then the second problem was there was a COVID pandemic, and can this course be administered online? And I realized here I missed a really important part of all this. In the D2K section here, one of the impetus for renewing this course was a realization that the proportion of patients coming through our clinic with mild cognitive impairment was greater than people had suspected. Many of my geriatrician colleagues said, well, it's good that we do things for mild cognitive impairment, and I see patients with mild cognitive impairment, but I think it maybe counts for 10 to 15% of the patients who come through our clinic. But what we started to do is making sure that we were collecting the data on, the diagnosis of the patients coming through the clinic. And it turned out that it's actually about 40% of patients. And this is a population where there are not really any pharmaceutical options. And so it's important to have something to offer to these patients because they're asking for help and we don't have a drug that can help. So what can we do to help? So the occupational therapist who kind of took charge of reviewing the psychoeducational course said, well, rather than just renew the course that's there, let's do a more broad literature review and look at other courses that already exist and other psychoeducational interventions, and identified a course that has been developed at Baycrest in Toronto, Learning the Ropes for MCI. Now, I actually trained at Baycrest and I knew of this course, but it was quite refreshing to hear my colleague kind of come up with it independently without me ever suggesting it. So they've done quite a lot of research to validate the outcomes with this course. And in fact, as the pandemic hit, had done some research to show that the course can be implemented online. And so a decision was made that says, well, rather than reinvent our own local course, we can maybe take an off-the-shelf course where there already has a lot of data backing it and implement it locally. So this is an example of this course here as advertised in Toronto. And so we said, yes, we're going to implement it locally, but again, we're going to make sure that we capture data from the patients going through the course. So there are going to be some outcome measures in terms of patient satisfaction, quality of life, and some patient-derived objectives in terms of what do they want to get out of the course and do they meet those objectives at the end of a course. And there was deliberate pre- and post-course data collection. This was done in the guise of quality improvement, not as a research project, because it was important that this was something we wanted to offer to patients anyway. So the data collection is happening sort of embedded within the clinical care that we're giving patients here. When we look at outcomes, I like to look at the Johari model. This is really meant to be a model of how you think about things that you're talking about with your therapist. But I think it comes, it is a useful model to think about when you have insights gained from any sort of investigation or research. So there are things you go into it knowing that you'll probably get or that you're looking at. There are things that you as the team doing it may not know, but either the participants in the project or other members will know. There are things that you know, but that you're not really intentionally putting into your project. And there's just things that nobody knows. So what did we get out of this education course? Well, we saw, as we thought, and kind of in par with this course that has already taken place in Toronto, participants were satisfied. They showed improvements in quality of life and a number of different measures that were on par with the reports that had already been presented. A hidden outcome is that we couldn't really directly compare this against the previous offerings because we didn't have any data on the previous offerings. One outcome that wasn't really thought of before in the blind spot was that there was actually a huge need for caregiver support. So when we ask simple surveys, you know, what could be improved in this offering in the future, it's more emphasis on caregivers, and I'll come to that in a minute. And then something we didn't necessarily expect because it contradicted the experience in Ontario was that really the online experience was not as good as was originally thought. And that was good in terms of how we were going to structure future offerings of this, because we knew as soon as we could go back to in-person, we probably should, because that's what people were telling us. So then we fed this back in and we said, well, we'll try to continue to offer the course. And now, of course, we're dealing with funding and logistics for that. We learned that we need to favor in-person over virtual groups. We need to tailor content based on feedback. But then this issue of the caregiver support really came out, and we did a bit of a deeper dive. And this is where I acknowledge my ignorance. I didn't realize the literature that's out there that shows that care partners of persons living with mild cognitive impairment experience as high, if not greater, distress than the care partners of people living with dementia. And when you start to unpack it, it kind of makes sense, because you're living with someone who's still functioning well, but has these deficits. And so you're getting into arguments, you know, well, I already told you that, or why didn't you do that? And you know, and yet there's not a lot of structured support out there as there is for dementia care partners. And I'm not saying that to say that it's easy to be a dementia care partner. partner, it's challenging, and I've seen it in a lot of my patients and personally in my family members. But we are fortunate now that there is a bit more support in place and more information in place for those care partners, whereas partners of persons living with MCI feel that there's less resources out there for them. And so that allowed us to spin another little group and start to collect information from people coming to our clinic about distress that they were experiencing as a care partner of somebody living with MCI, and to incorporate new sessions into this group that we're going to specifically target the care partners. So I'll give another example where we kind of tried to apply this methodology, but in a different way. So one of the things we're always looking at is how can we modernize our cognitive assessments, and something that has been quite fashionable in the literature is dual task gait analysis. So for those of you who are not familiar with this, there are umpteen variations on the concept, but they basically all are the same, is that you measure the person's gait, whether it's gait speed or other parameters of gait, and then you give them a cognitive task and then see what the load is of the cognitive task on their gait. So it's the old walking and chewing gum, so when you get the person to chew gum, it's not literally chewing gum, you get them to do things like counting backwards or other cognitive tasks. What is the cost of doing that cognitive task on the gait speed? And this has been shown as a pretty sensitive measure of people who are going to have progression of their cognitive impairment. So we thought, well, this is a great tool that we can start to incorporate into our clinic now to give us more information on these patients. And so the literature identified the dual task cost as a marker of cognitive deterioration, and our nurse and our therapist in the clinic looked at, what's a feasible paradigm that we can adopt in the clinic. And in our little computer system, we set up a way where they could report those figures back. And so we could start to right away capture the information on our patients' scores on this dual task gait task, and also report back to the care team about, well, how's your patient doing? And so what we saw is that it was easy to do. It wasn't a complicated thing, but it actually ended up consuming a lot of time of the therapist. And how do you add this into a clinic visit, and what do you subtract from an existing clinic visit in order to be able to accommodate the time? But more importantly, even though we were getting numbers, the clinicians felt that they didn't know what to do with that information. And most of the time they said, well, this doesn't really change what I'm thinking about this patient anyway. And so we said, well, maybe actually this is not ready for clinical implementation, despite what the external evidence says. Our local evidence says that, yeah, we can generate the numbers, but the clinicians don't know what to do with it. So we've liaised with the School of Exercise Science at UVic, and we're planning a more in-depth research study. And so this will actually be a separate research study where we will have patients who come through to the clinic who will be provided the opportunity to participate in the study, and they will go to the gait lab at UVic, where they will have other aspects of gait looked at, as well as dual task cost. And we're going to try to look at how could we put the information back together in a way that clinicians would be more apt to act on it. So what are the facilitators of this approach? Well, in our case, it's been philanthropy to ignite the flame, and also to provide ongoing support. And that ongoing support takes place in a couple of roles that are funded by our hospital foundation right now. So we have a learning health system facilitator who can help us look at, how do we set up our data structures to capture information, and which projects do we prioritize in our clinic, for example. We have a funded position for a data manager that actually helps us to build some informatics systems that are going to collect the information that we need, and buy-in from the health authority. So the clinical positions that are funded from the health authority within our memory clinic have some protected time for that's not direct one-to-one patient care, so that they can actually sit back. So if an occupational therapist is funded to deliver a group intervention like this, they also are funded to take the time to analyze the surveys and the information that we're getting back, so that they can keep on improving things. And so that moves away from the model of having a separate professional practice or a separate nurse educator who kind of just interacts in a top-down manner. And as I mentioned, this novel position, the learning health system facilitator, really blends an education, professional practice, administration, and research role. And as we're fumbling our way through this, then flexibility has been the key. Communication with stakeholders and making them part of the community of learning has been a really important facilitator for this as well. So challenges is carving out time and funding for any activity that goes beyond just what you have to get through in that day in the clinic, and that's always an issue. It requires a huge mind shift for health funders. Prioritizing problems, because there's no shortage of questions to tackle in healthcare for sure. And getting the data systems working, whether those are local systems like we have what's called the Dementia Guidance System in our clinic, or integration into the larger health authority electronic medical record, for example, and integrating usual clinical operations and structures into this model. And more importantly, keeping the patient need at the center of all times. And that's something we're really embarking into here, is recruiting patient partners into more of the projects that we undertake in our clinic. So I gave you some kind of low tech examples to show how just the approach from a mental perspective can happen with relatively little in terms of advanced technology. And I think a learning health system does not need to be complete in order to produce useful outcomes. This is something that one of my medical directors talking with me at the hospital said recently, and I thought that was encouraging.